Alright, so this is just a brief overview of anatomy and physiology for the cardiovascular system as kind of an introduction or a prep for Unit 3. So we're going to talk about the vascular system, which consists of arteries, veins, and capillaries, and the heart. So we want to talk about the tissue layers, chambers of the heart, the valves that separate the chambers, and of course the coronary arteries. Any and all of these portions of the system can be affected to cause a disease or be involved in a disease process. So again, having that basic understanding of the anatomy, where things are, and the physiology, what they do, what their role or function is inherent to understanding the disease process. So if we look at first the circulation, of course the center of the circulation essentially is the heart. The heart functions as a two-sided pump. The right side of the heart pumps blood into the lungs, and the left side of the pump, or the heart, pumps blood into the body. Because blood on the right doesn't have as far to go, it doesn't have as much vasculature to go through, it has less resistance, and so the right side of the heart is considered a low pressure pump, and the left side of the heart is a high pressure, so that, because of the greater, if you considered the length of the circulatory system of the body versus the length of the circulatory system of the pulmonary system, the body is considerably longer. So there's more length, there's more volume, there's more resistance, and so the left side of the heart has to work harder. So in the normal heart, the pressure is always highest in the left side, or the left chambers. So the left has a tendency to have more muscle tissue. If we were measuring pressure-wise, then the pressure of the blood leaving the left side of the heart is going to be greater than the pressure in the right side, leaving the right side of the heart going to the pulmonary system. Remember that as a general rule, arteries, well, let me back up a minute and say arteries always carry blood away from the heart. As a general rule, that blood is always oxygenated. The exception being the pulmonary artery. The pulmonary artery carries deoxygenated blood from the right side of the heart to the lungs, where it's oxygenated, and then returns to the left side of the heart to be circulated throughout the body. So veins come to the heart, return blood to the heart, generally are deoxygenated except for the pulmonary vein, which comes directly from the lungs and so is highly oxygenated. And as it circulates through the heart, it's going to go through a series of valves, and there's always a routine or a designated path that the blood flows through. So when it comes into the right side of the heart from the body, it flows into the right atrium and is held in the right atrium by the tricuspid valve being closed. When the tricuspid valve opens, it allows the blood to flow into the right ventricle. And when the right ventricle contracts, it causes the tricuspid valve to close and the pulmonic valve to open. And so blood flows out of the right ventricle and into the pulmonary artery through the pulmonic valve. Then it goes through the lungs and it comes back to the left side of the heart into the left atrium, where it's held by the mitral valve. And when the mitral valve opens, that blood flows into the left ventricle. When the left ventricle contracts, forces the mitral valve closed, and the aortic valve opens, and oxygenated blood is circulated through the body. Now you want to ask yourself, why is it important that we understand these factors? Keep in mind that if something happens perhaps to the mitral valve doesn't close all the way. Blood is continuously leaking from the atrium perhaps into the ventricle. But more importantly, what happens is every time that left ventricle contracts, a little bit of blood is forced backwards into the left atrium. The problem then becomes that now there's blood left in the left, in the left atrium. Not as much blood can come in from the pulmonary vein. So blood begins to back up in the pulmonary vein, and so now we have fluid not leaving the lungs. So think of that backward pressure, and what are we going to see eventually? If we have congestion of if you think of it as a highway going through the lungs, then we've got this, for example, 4-lane highway that typically goes through the lungs and dumps into the left atrium, no problem. Well, now we have this problem with our mitral valve, and things are starting to back up, and now we've got this 4-lane that's narrowed down to 3. And so we're starting to get back up. And then it narrows down to 2 or even 1, and we have more backup. So now we have all this blood that stays in the pulmonary vein, and it backs up into the pulmonary capillaries and arterioles. And what happens to that fluid, that blood, when it starts to just sit there? Okay, so that's the process you want to go through. So what are you going to see when that happens? Now we also want to consider, the heart as a two-sided pump. Why do we care? Or why is it important to understand that it's a two-sided pump? If one of those pumps fails, then it becomes inefficient. So if the left side of the heart becomes an inefficient pump, again, we have to think, what is going to happen? So the role of the left side of the heart is to pump blood out to the body. But if it's not contracting forcefully, then blood is going to stay in there. And again, we get the same kind of problem that we get with mitral valve prolapse, in that the blood stays in the left ventricle, it begins to back up into the left atrium, it begins to back up into the lungs. So we begin to see symptoms of heart failure, just because the heart has become an inefficient pump. Now if we look at the right side of the heart, think about where is that blood going to back up to? If the right ventricle isn't pumping blood into the pulmonary artery, It's going to back up into the right atrium, and then it's going to back up into the vena cava and the rest of the body. So now what symptoms are we going to see? So you begin to see how understanding the anatomy and how things are supposed to work can help you understand the symptoms that we're going to see of left-sided or right-sided heart failure. So you can apply this information to clinical by thinking about what those symptoms are, why it's occurring, and get a better idea of what it is you're going to do about it. Now, the other thing I want to talk about here is blood pressure. Now, we spent a lot of time learning how to take blood pressures, talking about hypotension and hypertension. But we haven't spent a lot of time on understanding the physiology of blood pressure. So if we think of blood pressure as the force exerted against the walls of the arteries, then it gives us an idea of how changes to the peripheral vascular system are going to affect our blood pressure. So if we get, we also need to think about the factors that control blood pressure. And some of the primary factors affecting blood pressure or affecting peripheral vascular resistance, which is going to impact blood pressure, include the viscosity of the blood. How thick is it? Because the thicker it is, the harder it is to move around. The length of the vessel. The longer it is, the more pressure is needed to move blood through there. And the diameter of the vessel. The narrower it is, the more pressure is needed. So if we have thick blood and or long vessels and or narrow vessels, all of these things together is going to give us high blood pressure. So that tells us that anything that constricts or narrows the diameter of the vessel, such as constriction because of medications, I had a thought and I lost it. Atherosclerosis narrows vessels because it builds up inside there. Those things are going to contribute to high blood pressure. Okay? So this is kind of showing the, on the left hand side you're seeing a picture that shows the layers of the heart. So we have the epicardium, which is the outer surface, and this is that thin tissue that covers all of our organs that acts like a protective layer. The outermost layer of the epicardium is the pericardium. It's that double membranous sac. We talked about that when we talked about lungs and the pneumothorax. So here's the same idea, that it allows the heart to beat and move without causing friction against adjoining organs. So remember that that double membranous sac has a thin layer of fluid that allows the two surfaces to slide over each other. So the epicardium is that very outer layer consisting of the two layers of the pericardium. The myocardium is the middle layer, and the word myo, or the prefix myo, should lead you to the understanding of muscle. So it's the muscle layer. This is where the actual work of the heart, the contraction and relaxation occurs. And then the endocardium is the inner lining. It lines the inside of the heart chambers and covers the valves. So again, it's just like a thin layer of saran wrap in there. When you're looking at the heart, one of the things I always think is interesting is that the base of the heart is actually at the top. If you were visualizing it, the base of the heart is usually located at the second intercostal space, and a little bit to the left of the sternum. Then the apex of the heart is at the bottom, and again usually located at the fifth intercostal space, midclavicular line and left midclavicular line. And this is usually where you're going to hear the PMI, or the point of maximal impulse. This is where we usually get the best heart sound when we're listening to heart sounds. The picture on the right shows the coronary arteries. It's important that you understand that the heart muscle is not nourished or oxygenated by the blood that it pumps. It has its own set of arteries that come off of the aorta that surround the heart and provide it with oxygen and nutrients that it needs. Now, it's important to understand that, because damage to these arteries is what sets us up for angina or myocardial infarction or heart attack. These arteries, when blocked or spasm occasionally, can damage the heart muscle. So think about that. What is the consequence of damaging the heart muscle? With angina, we get a brief interruption of oxygen supply, and so we get ischemia. And that's going to cause pain. It's always interesting to me to note that the heart itself, we don't sense pain directly from the heart. It's always going to be referred pain. And that's why people complain of, their left shoulder hurting, their jaw hurting, the pressure on the sternum, or severe epigastric discomfort, because we're getting that referred pain and not pain exactly from the heart. But anyway, if we damage the muscle and actually cause necrosis, which is what happens in a heart attack, then you have to wonder, can the heart do its job? What is the heart's job? The heart's job is to pump blood through the lungs, through the body. It requires intact, strong muscle to do that. So if we have an area of necrosis, does the heart become an inefficient pump? And if it does become an inefficient pump, besides pain, what other symptoms are we going to see? We're going to see that it's not able to do its job. And so depending on where the injury occurred, then we're going to see those symptoms. Now I just have two separate pictures here of the conduction system. Most of you probably remember from A&P that the stimulation for the heart muscle to contract is an electrical current. The electrical current starts in the SA node, or the sinoatrial node, is transmitted to the AV node, or atrioventricular node, to the bundle branches, and then into the Purkinje fibers. Now, I don't expect you as part of a test to be able to name that off. But I do want you to understand that the sinoatrial node is the primary site for that electrical conduction. However, any area along that conduction system can take over. Frequently the AV node might take over, or even an area along the bundle branches can take over. On the reverse side, we can have blockages so that the SA node might be signaling, but the AV node isn't picking it up. Or there might be a blockage along the bundle branches, and so think about what happens then as well if the signal is not being sent all the way through. You know, if the signal for that muscle to contract isn't reaching that muscle, is that muscle going to contract? And if it doesn't contract, what happens? You know, well, we don't get blood flow, and that's really not compatible with life. But also it could be incompatible with life if we have irregular, if we have more than one place telling the heart to beat. So I want you to think about that for a few minutes. Think about the normal flow of blood through the heart and superimpose the conduction system on top of that. So blood comes into the right atrium. The SA node says atrium contract, which the atrium contract and it sends blood into the ventricles. And there's a slight delay between the SA node and the AV node to allow that to happen. Then the AV node contracts, or gets the signal and shoots the signal through the bundle branches, which tell the ventricles to contract, and shoots the blood throughout the body. So what happens if the AV node says, I'm tired of being told what to do. I'm going to do my own thing. I'm going to contract when I want to contract. I'm not necessarily going to contract just because the SA node tells me to. So the SA node sends out a signal, and the AV node gets it, sends the signal out, and then decides, hey, I'm going to send another signal out. What happens then is that the atria haven't had time to fill, because the atria don't contract unless the SA node tells them to. When the AV node sends out that second signal, the ventricles contract, but there's not any blood in them because the atria haven't contracted. So we get this extra beat that is not doing anything. Now, if that happens occasionally, it's not a big deal. But if it happens frequently enough, then we have what? We have poor cardiac output. And that's really what I want you to understand, that when we have a dysrhythmia, when we have a missed signal, or we have an extra signal, that the heart's ability to pump blood, the cardiac output, is going to be affected. So think about, how will you assess for an arrhythmia? What might the patient tell you that they're experiencing? And what will you observe that indicates? So that, you know, think about what your assessment factors would be. And think about what your interventions would be based on that. Obviously, a lot of nursing interventions are going to be symptomatic. I mean, we're going to treat the symptoms. We have to have medical interventions to truly take care of it, but that doesn't mean that you can't anticipate those as well. Now, the little picture on the right is just showing you, when you look at a heart monitor strip, which I have at the one at the bottom, and by the way, this is showing normal sinus rhythm. I am not asking you to learn all the different types of rhythms. But I do think it's important to understand a couple of things. When we're looking at a strip, we're looking for the P wave, the QRS wave, and the T wave. You can see that those things correlate to where the signal is in the heart. So the P wave tells us that the SA node has fired and the atria are contracting. The QRS wave tells us that the AV node has fired and the ventricles are contracting. And then the T wave tells us that the ventricles are recharging. They're building back up, getting ready to fire again. Or I guess the bundle branches would be more like. But this is, so, you think about the conduction that's occurring. So P wave means the SA node's fired. The QRS tells us that the AV node is fired and it's moving through the bundle branches. And then the T wave tells us that the bundle branches are recharging. And that's a relatively simplified definition, but it gives you a basic understanding. So now let's think about the blood flow while that is occurring. So the SA node fires, tells the atria to contract. The atria contracts, which the force of that causes the tricuspid and the mitral valves to open. Now remember that the ventricles are relaxed, so it's a relatively low pressure in the ventricles at this time. So atria contract, blood flows into the ventricles from the atria. The AV node fires, sends the signal to the bundle branches, and now the ventricles will contract. That increases the pressure in the ventricles, causing the tricuspid and mitral valves to close and the aortic and pulmonic valves to open, which then causes blood to be forced out of the ventricles and into the body or into the lungs, wherever it might be going to go. So if you think about it, if you're looking at a strip, so let's look at the bottom strip, and you can see immediately on the left-hand side there's a little bump. Well, that's a T wave. So now we have a P wave, our QRS, and then a T wave. So that's a complete cycle. What we have on this strip is normal sinus rhythm, and at some point in time next year you will learn how to determine rate and all of that by looking at this strip. At this point in time, nobody cares, okay? But you can see there's a P wave, there's a QRS, and there's a T wave. The fact that there's a P wave tells us that it's sinus rhythm, that the SA node is the one that is signaling, that is causing the electrical signal. Okay. So really that's the main thing that I want you to know. You don't need to understand that big squares mean this, little squares mean that. It's just not that big a deal. Normal sinus rhythm is a regular rhythm. It's usually between 60 and 100 beats per minute, which is our normal pulse rate. So that's kind of where you want to be. You want to think about, if your patient is on a monitor, what is the first thing that you want to do when you see an abnormal rhythm? So just think about that, and we'll talk about that more in class. Now, cardiac output, you've heard me talk a little bit about before. Cardiac output is the volume of blood that the heart pumps per per minute. So cardiac output is heart rate times stroke volume. Stroke volume is the volume that is ejected with each heartbeat, or with each ventricular contraction. So if, as a general rule, the stroke volume is 70 and the heart rate is 60, then we get 4,200 milliliters of blood being pumped per minute. And that's what cardiac output is the amount of blood pumped in 1 minute. So imagine then, if stroke volume stays the same, what happens when we increase the heart rate? We're going to increase cardiac output. Same thing is going to happen or the opposite will happen if we decrease the heart rate. If we decrease the heart rate, but stroke volume stays the same, then cardiac output falls. But we have to keep in mind that that's a compensatory mechanism, meaning that if need be, the heart can alter heart rate and stroke volume, or it will alter heart rate in order to maintain cardiac output in response to changes in stroke volume. For instance, a patient that has lost a significant amount of blood will have a lower stroke volume. They don't have as much volume in their body, so their stroke volume goes down. So the body's response to that is to increase the heart rate to maintain cardiac output, because we have to have a certain level of cardiac output in order to meet the needs of the brain and the kidneys and all the other organs. So usually heart rate is going to respond to changes in stroke volume. Now, a couple of things that also affect stroke volume is the volume of blood coming into the heart, which is considered preload. We can have an increased preload if we have hypervolemia, or if the valves are not functioning properly. So if the tricuspid valve isn't closing entirely, then every time the right ventricle contracts, a little bit of blood goes into the atrium. That mixes with the blood coming from the body into the right atrium, and now we have an increased preload. So, or it could happen on the left side as well. Afterload is resistance that the left ventricle must overcome to circulate blood. Now remember, left ventricle goes to the body. So whenever we have vasoconstriction, whenever we have significant atherosclerosis, these things are going to increase afterload, or the resistance that the heart has to push the blood against. These things can alter cardiac output. Obviously, if the heart meets a lot of resistance trying to pump that blood out, cardiac output is going to fall, and so heart rate is going to go up. If I have too much blood coming in, the heart wants to get that circulated around, and the heart rate may go up. So those are the things that we want to consider with cardiac output. And then the last thing is the cardiac cycle. And I've kind of already talked a little bit about this. Primarily, the basic is diastole. We're primarily talking about ventricles when we're talking about cardiac cycle. Diastole is when the ventricles relax and they're filling. The atrium are contracting and pushing blood into the ventricles. And then systole is when the ventricles are doing their job and contracting and forcing blood out of the heart. This correlates to your blood pressure. So the diastolic number is when the heart is relaxed, and the systolic number is when the heart is doing its most work. So when we have an elevated systolic, then that tells us that there's resistance being met somewhere. The heart is pumping against a lot of resistance, or there's a lot of volume that the heart is trying to push around, and that's all increasing the workload of the heart. And eventually it's going to wear out the heart, and guess what? Make it an inefficient pump. So just, you can follow that, and again, go back to the valves and think about what's happening. So the other thing I want to mention is that when you're listening to heart sounds and you're hearing the lub-dub, you're hearing those valves close. And so when you hear those sounds, the action has already happened. And that might make more sense later, but I just want to plant that seed for now. So that's the basics of A&P that I want you to have an understanding of before we get into disease processes. So if you would like more information or you need something clarified,